Hello, it's a pleasure to be with you. This is Stephen Vernino from UT Southwestern Medical Center in Dallas. I run the Autonomic Clinic here in UT Southwestern, and I'm interested in autoimmune disorders. So I'm going to be talking this morning about autoantibodies in autonomic and peripheral nerve disorders. I'll start off with a little background anatomy. There are many places in the peripheral nervous system where autoimmunity, inflammation, or autoantibodies can play a role. Here's the somatic nerve system. So we have sensory nerves and motor nerves that are combined to create the mixed peripheral nerves out in our body. And proximally, there's the dorsal root ganglia, where the cell bodies of sensory neurons live. That's one site where autoantibodies could play a role. And then there's the nerves themselves. There's a variety of nerves within each of the nerve fibers. There are motor nerves, sensory nerves, and autonomic fibers. Some of these are large myelinated fibers, some are small unmyelinated fibers. Either of these can be targets of autoimmunity. And then finally, in the large myelinated nerves, the myelin structures themselves can be targets of autoimmunity, leading to specifically demyelinating disorders. On the autonomic nervous system, the anatomy is a little bit different in the sense that there are peripheral autonomic ganglia. The nerves in the spinal cord extend out and synapse in the peripheral ganglia, and then the postganglionic neurons extend out to end organs. So the autonomic ganglia themselves can be a unique target for autoimmunity, as we'll hear about in certain autonomic and autoimmune disorders. There are synaptic proteins in the autonomic ganglia, as well as in the multiple autonomic ganglia within the enteric nervous system. The autonomic end organs are unique in the sense that norepinephrine and acetylcholine are used to stimulate various targets in the heart, in the pupils, in the blood vessels, and these receptors can be targets of autoimmunity as well in some cases. And then finally, as we know, the neuromuscular junction can be a target of autoimmunity in disorders like myasthenia gravis or Lambert-Eaton syndrome. I won't talk about those so much today. And likewise, the muscle, there can be autoimmune disorders of muscle with specific autoantibodies. We're talking mostly about nerves today, and I'll start with the autonomic nervous system. So there can be long-standing chronic peripheral autonomic neuropathies, sometimes called PAN, peripheral autonomic neuropathies. And in the chronic state, most of these slowly progressive autonomic neuropathies are not autoimmune, but I wanted to review some of the common causes. Diabetes or amyloidosis can cause small fiber neuropathies that have prominent autonomic features, so that's good to be aware of. Sometimes the small nerve fibers can produce more of a sensory neuropathy with also autonomic features as well. And we can see this in some immune diseases such as Sjogren's syndrome, but also in states of nutritional deficiency, alcoholism. Many of these small fiber peripheral neuropathies are idiopathic, and there's a lot of research going on to determine whether some of these may be immune-mediated. We don't yet have autoantibody markers. There are, of course, some rare inherited autonomic disorders I mentioned in passing. These are usually presenting in young people due to specific mutations in proteins that are important for the autonomic nervous system. As people get older, their autonomic nervous system tends to reduce in function. So some of our autonomic features in older patients, including changes in blood pressure regulation, changes in gut motility, sexual dysfunction, are just part of normal aging and not really considered pathological autonomic neuropathies. But there are some neurodegenerative conditions that affect the autonomic nerves, especially those associated with the accumulation of alpha-synuclein, such as pure autonomic failure, multiple system atrophy. Again, most of these chronic disorders are not immune-mediated. And then finally, we sometimes see some restricted peripheral autonomic disorders, such as idiopathic anhidrosis or loss of sweating, AD syndrome, where one or both pupils stop working. And it's unclear what causes these, but given the onset of these, usually in a subacute way and then a chronic state, that they may be immune-mediated. Now, on the other hand, when autonomic neuropathies or autonomic dysfunction occurs in an acute or subacute fashion, we consider the possibility of an autoimmune-mediated neuropathy or ganglionopathy. And the most characteristic of these is a disorder that's been near and dear to my heart for 20 years or so, autoimmune autonomic ganglionopathy. We'll talk about that in some detail. So that's a disorder where patients get a pretty severe autonomic failure. You can see a similar thing in the setting of cancer, in a paraneoplastic autonomic neuropathy or neuronopathy. And those can be associated with various different cancers and various different antibodies, as we'll discuss. There are also a variety of inflammatory sensory and autonomic neuropathies, similar to those small fiber neuropathies, a lot of pain and autonomic dysfunction. And some of those are inflammatory, and some of those have some autoantibody markers associated with them. Similarly with those that are more limited, such as an acute cholinergic neuropathy. And then keep in mind that not all acute or subacute autonomic dysfunction syndromes are autoimmune. We can see the same thing in certain toxins, including botulism and so on. So what is this autoimmune autonomic ganglionopathy? This is a rare disorder, but one that's quite distinctive, usually occurring in middle-aged patients, slight predominance of women. These are patients who present rather suddenly over the course of just a few weeks with severe orthostatic hypotension and GI hypomotility, often constipation, but also gastroparesis as well. So about 70% of patients with AAG have both of these features. So severe orthostatic hypotension leading to fainting when people stand up, and really major problems with GI motility. In more severe cases, urinary retention can occur, and even impairment in pupillary function, so dilated, unresponsive pupils. Now, although this is a pure autonomic disorder, some patients have tingling sensations or other sensory symptoms, but typically the examination of sensation is normal, and tests such as nerve conduction studies are normal as well. Important to note that when you test these patients formally for autonomic function, they have severe autonomic failure in multiple domains, and even their plasma norepinephrine levels, which is a measure of how the sympathetic nervous system is working, tend to be reduced. So we found many years ago that half or more of these patients have antibodies against the ganglionic acetylcholine receptor. That's the receptor that mediates fast synaptic transmission in all autonomic ganglia. Sympathetic autonomic ganglia, parasympathetic autonomic ganglia, and autonomic ganglia synapses in the enteric or gut nervous system. And oftentimes the titer is quite high. We'll talk about antibody levels in just a minute. But I want to make a few points about AAG because it's often misdiagnosed. Remember, it's a rare disease. As an expert, I really only see 2 or 3 cases a year. So most clinicians will never see a true case of AAG. Orthostatic tachycardia, in other words, patients who feel dizzy when they stand up, associated with elevated heart rate and not a drop in blood pressure, that is not AAG, and that's a condition called postural tachycardia syndrome we'll talk about in a little bit. AAG is an important one to diagnose, though. This test for ganglionic acetylcholine receptor antibodies is now commercially available from a number of different places. And if this is the diagnosis, these patients may improve quite nicely with immunotherapy. Unfortunately, sometimes the improvement is only partial, and they're left with some degree of autonomic dysfunction. So this was a figure from the initial publication in 2000 that described ganglionic acetylcholine receptor autoantibodies. And you'll notice that on the y-axis, this is a logarithmic scale. So some of these antibody titers are quite high in this first group, which is the idiopathic subacute autonomic neuropathy, or AAG patients. And you can see in the second row there, second column, that patients with paraneoplastic or cancer-associated autonomic neuropathy may also have high levels of this antibody, but these antibodies are rarely found in other conditions, including healthy controls and other patients with GI dysmotility. When we first published this paper 22 years ago, we established the normal value for this antibody of 0.5 nanomoles per liter on a radioimmunoprecipitation assay. Once the assay was commercialized and went into more widespread use, we've discovered from experience that the clinical significance of the antibody is really most notable for antibodies that are much higher, with a cutoff value of about 0.2 nanomoles per liter. And so there's a group in between that are low positives where the significance of the antibody is somewhat unclear. So to state that in another way, you can divide up clinical phenotypes according to the level of ganglionic acetylcholine receptor autoantibodies in this way. So on the top there, subacute pandysautonomia, the classic presentation of autoimmune autonomic ganglionopathy, are those associated with really quite high levels of the antibody, greater than 1 nanomole per liter. And this is often a subacute onset monophasic illness with widespread autonomic dysfunction, severe orthostatic hypotension, and gut dysmotility, and often, even with treatment, some residual impairment of function. Then there's a group in between that have high antibody levels, again, greater than that 0.2 cutoff, but lower than the classic case of AAG. And these tend to be patients who have more limited autonomic failure, can look somewhat like a condition called pure autonomic failure, which is a neurodegenerative condition, except that these patients often have a lot of GI and bladder symptoms and may have abnormalities in their pupil. In fact, there's a characteristic impairment of the pupillary constriction function that's almost pathognomonic for AAG. And then finally, it's important to note that many patients who have low antibody levels, in other words, less than 0.2, that scenario is quite nonspecific. So we see low levels of ganglion receptor antibodies in patients with postural tachycardia, with various types of GI dysmotility, and in many patients who really don't have any autonomic dysfunction at all. And over time, we found that this antibody may be poorly specific, with up to 3% of control healthy patients having low levels of this antibody. And in practice, based on some of these reports that I've listed here in the references, the majority of patients with antibody levels less than 0.2 actually don't have any autonomic or neurologic disorder. So the clinician must use judgment and caution when interpreting these lower antibody levels. Now, what about postural tachycardia syndrome, which I've mentioned a few times? Postural tachycardia syndrome, or postural orthostatic tachycardia syndrome, is recognized as the most common form of autonomic dysfunction that we see. And it's suggested that 1 million or more patients in the United States are affected by POTS. It's defined as orthostatic intolerance, meaning difficulty with standing up. That's associated with a excessive increase in heart rate on standing, greater than 30 beats per minute for adults, without a drop in blood pressure. And these patients not only have the orthostatic symptoms, but also many other symptoms such as GI issues with constipation or diarrhea or abdominal pain and bloating, lots of fatigue, and often some other pain complaints. So POTS is a kind of a diverse disease. It's been suggested that at least some cases of POTS may be autoimmune in nature. Why? Because POTS typically affects young women, which is a demographic that we often see autoimmune diseases. Onset of POTS may follow infection, physical stress, concussion, or other sorts of stressors that we think may stimulate the immune system. POTS is associated with other risk factors, including joint hypermobility, mast cell hyperactivity, and has been associated with other autoimmune diseases. Again, by guilt by association, that autoimmunity may be important. There's been a number of studies also that indicate that autoantibodies are more common in POTS patients than in the normal population, but it's nonspecific. Various antibodies, including antinuclear antibodies, ANA, antiphospholipid antibodies, acetylcholine receptor antibodies, include the ganglionic one, as well as adrenergic receptor antibodies and others. So what about this autoimmunity in POTS? So remember that, keep in mind that POTS is not one disease. It's quite heterogeneous, and the autoimmune variety of POTS probably represents only one of a number of etiologies that are important. Specifically, deconditioning can be very important in POTS patients, and that may be an entirely different etiology or pathophysiology. There's also genetic factors. These patients with joint hypermobility syndrome or hypermobile EDS may have a type of POTS that may overlap with the autoimmune condition, but also may be different. And then POTS can occur both in highly active people, but also in sedentary ones, and the pathophysiology may be different. So we're still doing a lot of studies to try to help isolate which group of POTS patients may have an autoimmune cause and may respond to immunotherapies. So autoantibodies can be an important way to look for that. So there was initial interest in ganglionic acetylcholine receptor antibodies, the same ones that I described in AAG, that may be important in POTS. Actually, in some initial reports, it was suggested that up to 7% of POTS patients may have ganglionic acetylcholine receptor antibodies, and it was thought that this may reflect that POTS is a form fruste of AAG in some cases. However, as time has gone by, as I mentioned, it's been noted that ganglionic receptor antibodies can occur in healthy control patients, and that may not be very specific for POTS. So here's a recent report that we produced with a large group of community-acquired samples from POTS patients and healthy controls. As you can see in the first graph, if you use a very permissive cutoff level for positivity, which is 0.02, that 7 or 8% of POTS and control patients may be positive for this antibody. So that permissive cutoff value is really not very useful. Even if you use the 0.05 nanomole per liter cutoff value, which was what we reported in our initial paper in 2000, about 3% of controls and about 3% of POTS patients were positive. Really no difference between POTS and controls, and no difference in the clinical correlations between those with antibodies and those with not. So we concluded from that really the ganglionic acetylcholine receptor autoantibody is not really a useful test in POTS patients. And I would point out also that if we use that 0.2 cutoff, that neither POTS nor control patients were positive in any subjects. Now, there's been increasing interest in other types of autoantibodies in postural tachycardia syndrome, and a number of publications over the last 10 years relate to antibodies against G protein coupled receptors. G protein coupled receptors are a large family of transmitter receptors that are important throughout the body, but also in the autonomic nervous system. The one that's been most commonly reported is autoantibodies against the alpha-1 adrenergic receptor. This is the main receptor on blood vessels that mediates vasoconstriction in response to norepinephrine, which is the main transmitter in the sympathetic nervous system. But antibodies against other G protein coupled receptors, including muscarinic receptors of various types, M2, M3, and M4 muscarinic receptors, the beta adrenergic receptors, and even the angiotensin receptor AT1. Now, there was a report back in 2014 that showed that antibodies and serum from POTS patients may actually alter the function of alpha-1 receptors in POTS patients. So here's some graphs just showing that the antibodies seem to shift the response curve, almost acting like a partial agonist to the alpha-1 receptor. So this is very interesting, and there are very detailed and somewhat complex descriptions of how these antibodies may produce the clinical phenotype of POTS. However, going back to the literature, G protein coupled receptor autoantibodies have been reported many times in healthy controls and in many other disorders, including cardiomyopathy, eclampsia, lupus. And so it was unclear whether these antibodies were at all specific or useful in terms of the diagnosis of POTS. And a recent paper that we presented at a meeting last year, will come out in press soon, we showed that G protein coupled receptor, at least the prevalence by commercial ELISA tests, is no different between POTS patients and controls. So this is a still evolving area of interest. And if these autoantibodies are important, there'll need to be some assay development to really define which of these antibodies have clinical relevance, which have physiological significance, and which may be nonspecific markers. So I want to change gears a little bit and talk a little bit more about autonomic neuropathy and neuronopathies that occur in cancer patients, because there's a whole different set of autoantibodies that are important here. So the most classic presentation is an autonomic disorder associated with usually small cell lung carcinoma. And the classic antibody associated with this is the anti-neural nuclear antibody type 1, or anti-HU antibody. And then less commonly, but also importantly, the CRIMP5 or anti-CV2 antibody that can be a marker of lung cancer in patients with a progressive autonomic neuropathy. It was interesting because enteric neuropathy, or autonomic neuropathy primarily affecting the gut, is probably the most common autonomic manifestation in cancer patients. So cancer patients may present with severe gastroparesis, nausea, vomiting, slow bowel motility, and that can occur in many lung cancer patients, often not diagnosed because nausea, vomiting, weight loss often is considered to be part of having cancer by many oncologists. But these patients often have autoantibodies associated with their cancer. Beyond that, patients can have an autonomic ganglionopathy in association with cancer. very similar to AAG with sympathetic failure, orthostatic hypotension, GI dysmotility, but differentiated from AAG in that these patients often have other paraneoplastic phenomena such as sensory neuropathy or limbic encephalitis with seizures and behavioral changes. So the best treatment for paraneoplastic autonomic neuropathy is treatment of the cancer along with immunotherapy, and that's sometimes helpful. So now I want to switch gears and talk more about neuropathy in general. We've talked about the autonomic nervous system up till now, but we've talked about paraneoplastic disorders. But it turns out that most likely, and most experts agree, that the most common type of paraneoplastic neurologic disorder is an axonal sensory-motor polyneuropathy, which is quite generic and can be due to many different causes. But when patients present with a progressive axonal painful neuropathy, the consideration of an underlying malignancy is important to think about. Unfortunately, antibodies don't help us a whole lot because these patients with axonal neuropathy in the setting of cancer usually don't have one of the recognized neurologic autoantibodies. In fact, some of these cases are related to peripheral nerve vasculitis as opposed to an antibody-mediated paraneoplastic disorders. So what kinds of things are suspicious about paraneoplastic peripheral neuropathies? They can be present with onset in the upper extremities, which is unusual as far as peripheral neuropathies go. There can be asymmetry. Some patients with breast cancer associated nerve vasculitis have intense itching, which is a useful diagnostic tool, or other signs of vasculitis. Now, if patients present with a neuropathy associated with other paraneoplastic syndromes, such as seizures, limbic encephalitis, autonomic dysfunction, then the suspicion for a paraneoplastic cause does increase. So we're talking about autoantibodies, and so I wanted to just show this list. This is a list of autoantibodies that are directed against targets in the nuclear or cytoplasmic regions of the neuron, nuclear or cytoplasmic antibodies. These are generally considered this is a short list of the classic paraneoplastic autoantibodies. What's important about these antibodies, because they target intracellular antigens, is that these are probably not antibodies that directly affect nerve function, but are really important and sensitive markers, specific markers of a cell-mediated immune response against cancer, which then also causes problems with the nervous system. The classic one, ANNA1, or the anti-Hu antibody associated with small cell lung cancer. And I've highlighted those that are associated with various syndromes because under the rubric of various syndromes, peripheral neuropathies are one of the more common ones. So ANNA1 can be associated with peripheral neuropathy or various other kinds of neuropathies, including autonomic ones, as I mentioned, as well as antineural nuclear antibody type 3, Purkinje cell antibody type 2, amphiphysin antibodies, and the CRIMP5 antibody. And you can see most of those are associated with small cell lung cancer or occasionally with thymoma. So what about autoantibodies? There has been some interesting work in fairly recent years on antibodies directed against components of the peripheral nerve, and in particular, those directed against targets in myelinated nerve. So here's a graphic I borrowed from the reference there, just showing the number of proteins and protein interactions that occur in myelinated nerve, mainly to help anchor the myelin and anchor the important ion channel proteins in the node of Ranvier, in the perinodal region, in the juxtaperinodal regions. So it's been recognized that antibodies against one or more of these nodal proteins or perinodal proteins can be important diagnostic markers in certain variants of chronic inflammatory demyelinating polyradicular neuropathy, or CIDP. CIDP is a progressive demyelinating neuropathy. It's often quite symmetric and progressive, but generally responds exceedingly well to IVIG, intravenous immunoglobulin. But it was recognized that some patients have a poor response to IVIG or have a more aggressive course, and those are the patients in which one or more of these perinodal antibodies has been identified. So these fall into two major categories. There are the ganglioside antibodies and other perinodal antibodies that we'll get to in the next slide. So gangliosides are these lipid proteins that are found in nerve membranes and are very important in regulating the function of nerves and the motility of proteins within the nerve membrane. The most recognizable or recognized one of these is the GM1 protein or GM1 ganglioside. And antibodies against GM1, particularly the IgM type, have been associated with various specific forms of neuropathy. In particular, anti-GM1 autoantibodies are found in a condition called multifocal motor neuropathy, where patients have neuropathy that is very patchy. It affects individual nerves, especially motor nerves specifically, throughout the body. Anti-GM1 antibodies have also been associated with the quote-unquote axonal form of Guillain-Barré syndrome, especially ones associated with the bacterial infection Campylobacter jejuni. It tends to be a more aggressive and severe form of GBS. So the anti-GM1 antibody can be very important as a diagnostic test in multifocal motor neuropathy or a prognostic test for certain types of Guillain-Barré syndrome. There are other gangliosides. The GQ1B autoantibody is particularly associated with a variant of Guillain-Barré syndrome called the Miller-Fisher syndrome, where patients develop predominantly cranial nerve abnormalities and balance problems, but also with other forms of Guillain-Barré syndrome, and with a type of encephalitis called Bickerstaff encephalitis, where patients uniquely get sleep episodes and brainstem abnormalities. Other gangliosides include the GT1A antibody and the GD1A antibody, which can be associated with specific variants of acute acute neuropathies in the GBS family. But again, different than run-of-the-mill GBS, the GT1A antibody is associated with pharyngeal, cervical, and brachial variants of GBS. And GD1A is another marker of an axonal motor form of Guillain-Barré syndrome. And then finally, MAG, which is not a ganglioside, but is a protein that interacts with gangliosides. Anti-MAG antibodies have been associated with a particular kind of distal and symmetric demyelinating neuropathy, often associated with extremely long distal latencies in the motor nerves. Other antibodies that have come to recognition in recent years are quite important in terms of their association with potentially immune-mediated or autoimmune small fiber neuropathies. And these include IgM antibodies against TSHDS, which is a sulfated protein involved with small fiber nerves, or FGFR, which is a growth factor receptor that antibodies against that have been associated with small fiber neuropathies. I will say that the association of these is quite clear. As far as whether these patients routinely respond to immunotherapy is still an area of research investigation. Now, what about these perinodal antibodies that I mentioned earlier? So in cases of refractory demyelinating neuropathy, CIDP, there can be antibodies against one or more of these proteins that are involved in anchoring the myelin just at the perinodal region. And the main ones are the contactin-1, Casper-1 complex. So those are proteins on the nerve that are responsible for interacting with neurofacin, specifically neurofacin NF155, on the myelin to anchor the myelin there. So it's thought that antibodies against one or more of these proteins causes the myelin to detach and peel away from the nerve, resulting in a demyelinating neuropathy. And because some of these antibodies are of the IgG4 type, it's felt that treatments such as rituximab or cyclophosphamide are more effective than IVIG in these cases. So I want to try to summarize. I've covered a lot of material here, but that immune-mediated neuropathies include various types. Demyelinating neuropathy affecting large myelinated nerves, axonal neuropathies, neuropathies that are primarily targeting small fiber nerves, or those that are primarily autonomic neuropathies. And these can include neuropathies affecting the axons of the nerves or the cell bodies or neuronopathies. In the autoimmune category, there can be paraneoplastic ones that are associated with underlying malignancy, as well as idiopathic forms of autoimmune disorders. There's a wide range of associated autoantibodies. Some of them are quite specific for certain diseases. Some of them are quite specific for the presence of underlying malignancy. And some of them are useful markers, but need to be interpreted with caution. These have different targets, and of course, we didn't go into much detail, but there are different assays used to assess these antibodies, which can have different assay characteristics with respect to sensitivity, specificity, and reproducibility. Those presentations that look like autonomic ganglionopathy or sensory ganglionopathy are those targeting the cell bodies that are much more likely to be autoimmune in nature. So at the end of the day, our autoantibodies, the list of autoantibodies that can be utilized in the diagnosis of the neuropathies is growing. And these autoantibody findings, as we learn more about how to interpret them, can guide our diagnosis and our therapy. So I want to thank everybody for your attention and for your interest in autoimmune antibodies in peripheral neuropathies. I'll be happy to entertain questions during the Q&A period.